Hello, my name is Steven Aguilar. My topic is cardiovascular risk reduction with Icosapent Ethyl for hypertriglyceridemia. Continue. Introduction. Cardiovascular events rates remain high in patients with cardiovascular risk factors who receive treatment for primary and secondary prevention. Even in patients receiving adequate treatment with statins, there is a substantial residual cardiovascular risk. Among patients with cardiovascular risk factor receiving treatment for secondary and primary prevention, the risk of cardiovascular events remain high. Even in patients receiving appropriate treatment with statins, there remains a substantial residual cardiovascular risk. The level of triglyceride servers has an independent marker for an increased risk of ischemic events, as shown in the Midland epidemiological and respiratory studies. In research trees, drugs that reduce triglyceride levels, such as methicillin and the prolonged release feed rate, have not reduced the rate of cardiovascular events when they are administered in addition to adequate medical therapy, including statins. Contemporary trials and recent meta-analyses and off-treat fatty acid products have not shown a benefit in patients receiving statin therapies. Continue video.
Elevated triglycerides are an independent marker of increased ischemic risk. Icosapent ethyl, a highly purified and stable EPA ethyl ester derived from fish oil, lowers triglyceride levels. However, it's not known whether it reduces ischemic events. In this multi-center randomized double-blind placebo-controlled trial, 8,179 statin-treated adults with persistently elevated triglycerides and established cardiovascular disease or diabetes, and at least one additional cardiovascular risk factor, were randomized to 2 grams of Icosapent ethyl twice daily or to placebo. The primary outcome was a composite of cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, coronary revascularization, or unstable angina. The key secondary outcome was a composite of cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke. After a median follow-up of 4.9 years, the primary outcome occurred in significantly fewer patients in the Icosapent ethyl group than in the placebo group. The key secondary outcome also occurred in significantly fewer patients in the Icosapent ethyl group than in the placebo group. Hospitalization for atrial fibrillation and flutter was more common with Icosapent ethyl. Serious bleeding was slightly but not significantly more frequent in the Icosapent ethyl group. The authors conclude that in patients with elevated triglycerides despite statin therapy, Icosapent ethyl significantly reduces the risk of ischemic events. Full trial results are available at nejm.org.
Okay, continue. Study. In Japan EPA lipid integration study, 6,500 Japanese patients with hypertriglyceridemia were assigned regularly to receive a treatment with low-intensity statins plus 1.8 of EPA dietary or statin therapy alone. The risk of major coronary events was significantly lower in 18% in the group that received EPA-borne statin therapy than in the group that received statin therapy alone. Reduce it. This consideration led to the design of the study reducing cardiovascular events with the intervention trial with ethyl icosapent. Reduce it. It is a high purity and stable EPA ethyl ester that has been shown to reduce triglyceride levels and is used as dietary supplements in adult patients who have triglyceride levels of the less 500 mg per deciliter. Continue video.
Honestly, when I first saw the data, I was just floored. I realized at that point that we were about to change the course of cardiovascular medicine. It's pretty well established that people that have elevated LDL cholesterol benefit from being on drugs called statins. What has been unknown is whether the same paradigm applies to people that have elevated triglycerides. Should they be on specific medicines to reduce their cardiovascular risk? That's what we set out to study in the REDUCE-IT trial. And this was a randomized trial of over 8,000 patients who were randomly assigned to either a drug, Icosapent Ethyl, the brand name for which is Vascepa, or to a placebo. And then they were followed for an average of about 5 years to see whether the drug would reduce their risk of bad cardiovascular events. Vascepa is being prescribed by some physicians right now for patients whose triglycerides are super high, above 500 milligrams per deciliter. We were studying it in people with lower triglyceride levels. Is it a risk factor for heart disease that we can modify? The results are really quite strong and in a statistical sense extremely rigorous. Patients randomized to Icosapent Ethyl had a 25% reduction in the risk of things such as dying from cardiovascular causes, stroke, heart attack, being hospitalized for chest pain, or needing procedures such as angioplasty or stenting. There was also a 20% reduction in death from cardiovascular causes. It's not clear to me that the majority of the benefit of this drug is just from the triglyceride reduction. It does lower triglycerides, but it does seem to have other sorts of biological effects. For example, cellular membranes, it appears, are stabilized by EPA, and it's possible that that sort of membrane stabilizing activity explains what we saw in the REDUCE-IT trial. For physicians involved in the care of patients with cardiovascular disease, or for doctors caring for patients with diabetes that have additional cardiovascular risk factors, I think that the trial results are going to be pretty broadly generalizable to a very large percentage of certainly the patients I care for as a cardiologist, but even for endocrinologists and primary care physicians. And that's in the context of a drug that was very well tolerated. Really, it was tolerated as well as placebo and reasonably safe. So for physicians who have found the results of REDUCE-IT immediately actionable to their patients, this is a drug that's already available for prescription use. It's not approved, as of yet at least, for the REDUCE-IT indication. So physicians will have to use their discretion about whether they want to use a drug off-label. That potential to actually improve patient lives, in some cases save patient lives, that doesn't happen too often in clinical trials. We now have a result that I think will improve the care and lives of patients throughout the world.
Okay, continue. I can also have anti-inflammatory, antioxidant, platelet stabilizer, and membrane stabilizer properties. Alone rates of the adverse events were generally low. Atrial fibrillation, edema, and severe bleeding were more common with ethyl icosapent. Hypothesis. We hypothesized that the risk of cardiovascular events would be lower with icosapent ethyl therapy than with placebo among patients in whom elevated triglyceride levels serve as a marker of residual risk. The paid treatment with statins. Continue to video. Continue to video.
The REDUCE-IT trial was a large randomized trial in approximately 8,000 patients with either secondary prevention or high-risk primary prevention, all patients on statins, and all patients with elevated triglycerides equal to or above 135 but less than 500. And it tested EPA, a purified formulation of omega-3 fatty acids, Icosapent Ethyl, for the prevention of cardiovascular events long-term. Now, what is particular in this trial, a number of features are specific to this trial. First of all, we used a high dose of EPA, 4 grams, far more than has been used in the past in the many previous trials of omega-3 fatty acids. and twice as much, or a little more than twice as much as was used in the jealous Japanese trial. The second feature is the patients all had elevated triglycerides. Now, with follow-up, what we found was, and this was largely unexpected, truly, we found a 25% reduction in the primary composite outcome of cardiovascular events. And when we look at the key secondary outcome of CV death, MI, and stroke, which is the conventional hard outcome used by most cardiology trials, there was also a 25% reduction. In addition, there was a 20% reduction in cardiovascular mortality. So these are major treatment effects associated with highly statistically significant and associated with very low numbers needed to treat and large absolute reductions in high-risk populations. Now, in terms of safety, the drug was reasonably safe. There was a statistically significant increase in the incidence of atrial fibrillation or atrial flutter by approximately 2%. There was a borderline increase in bleeding, and we know that omega-3 fatty acids are associated with decreased viscosity and potential platelet effects. And there were some modest differences in other side effects of lesser importance. So the overall result is a dramatic reduction in cardiovascular events for a treatment that has the potential to really be widely used in practice because it's not very expensive, it's reasonably easy to use and to take. And I would like to point out that this is a surprise because recently there was a meta-analysis that looked at all of the trials of omega-3 fatty acids, and most of the trials have been negative. However, most of the trials were done in lower-risk patient population at much lower doses, not with the purified EPA that was used in this trial. The only exception to that rule was the Japanese jealous trial, which actually was positive and found a 19% reduction, not inconsistent with our own findings. So there are two trials at high doses of omega-3 fatty acids with fairly similar preparations that were positive, and the rest of the trials used 1 gram or less of non-purified preparations and were negative. So I think we have some understanding that maybe dose might be critical. A couple of other comments. Triglycerides, we selected purposely patients with elevated triglycerides, but in the end it doesn't seem to matter because when we look at the treatment effect as a function of baseline triglycerides, the results are the same, and there's neither any interaction with achieved triglyceride levels after a year, doesn't seem to impact results. So it's probably not about triglycerides, and actually it raises the question of how does this work? And to be really fair, we don't really know. There are myriad hypotheses about benefits of omega-3 fatty acids, and with the current data we have, at this stage we're not fully sure of how it works, but what is clear is that there is unambiguous cardiovascular benefit.
Okay. Thank you.